It's been a real pleasure of mine to be involved with the stroke program here. Today we're going to talk about a very, very important disease process, stroke. The reason we're talking about stroke is because information in general about stroke is lacking, and stroke is one of the areas where the care has been transformed immensely in the past decades. So I want to bring everyone up to date about the basics of stroke, understanding stroke, and why stroke in particular is a disease where time is of the real essence. So today we're going to answer a few questions. So the questions are, what is a stroke? Who is at risk of stroke? Why do strokes occur? What happens after a stroke, and how should you be treated for a stroke? So we got a what, who, why, what, and how. So a few questions we're going to answer, okay? So first of all, I just want to start with a definition of stroke. So we're going to start with the Wikipedia definition of a stroke, okay? Wikipedia tells us it's a rapid loss of brain function due to a disturbance in blood supply. So in a stroke, the brain is often an innocent bystander where it's being affected by either a lack of blood supply or hemorrhage into the brain. So stroke is two different distinct pathologies. One is a blood clot forms somewhere else in your body or within the brain itself and occludes an artery, and you can't get blood flow into the brain. And the second is one of the arteries in the brain ruptures and a blood clot forms, spreading through the brain, pushing the brain aside. Both of those are strokes. The vast majority of strokes are ischemic due to lack of blood flow. A sizable minority of them are hemorrhagic due to bleeding in the brain. Okay? So the thing about a stroke is this. Occasionally, if that blockage breaks up by itself, you have what's called a transient ischemic attack, a TIA. Now, that doesn't sound like a very ominous term, transient ischemic attack, but those, to me, are the most interesting strokes, because a patient who's had a transient ischemic attack, a patient who's had an occlusion of a blood vessel which opened up on its own, that patient is free of disability. And in that patient, we can do an investigation to figure out what happened and how to prevent it. That is opposed to a patient who is aphasic, loses the ability to speak, and hemiparetic, loses the ability to function in one half of their body. We are interested in preventing stroke. We also have great therapies after you have a stroke, but if you have any neurological symptoms that are suspicious for a stroke, it's important to recognize that, and I'm going to tell you what to do when you recognize that. And remember, in a stroke, the affected part of the brain cannot function. So the neurological symptoms in a stroke reflect the brain underlying it. So I'm going to give you a little quick tour of the brain, a little quick tour of the blood vessels of the brain, and tell you a little bit more about what a stroke is, okay? So here's the brain. The brain is about 5%, 4% of the body weight, but it gets about 25% of the blood flow. It is, I would say, the most important organ in the body. And moreover, there's a functional organization in the brain. Different parts of the brain have different functions. I have here the functional organization of the right brain. So you see, music. We've had people who've had strokes and have become they've had amusia, inability to appreciate music. And for those of you who are music lovers, you recognize how important a disturbance that could be. Can you imagine being able to not appreciate music? You have vision here, loss of the visual field, not being able to see out of one half or the other half of your visual fields. Memory, visual memory, memory for faces. Inhibition, in the frontal lobes. The part of the brain that's affected will cause symptoms. The most important ones are the motor symptoms over here. Strength. The right part of the brain controls the left part of the body. And each section of the brain controls a different part of the body. Foot, leg, arm, and trunk. So you see, stroke symptoms are a reflection of the brain which has been injured or damaged. Now here is the left brain. The left brain has a lot more to do with language. The right brain has more to do with emotion. But both parts of the brain have to do with motor function, motor strength. Both parts of the brain have to do with vision and visual processing. The back part of the brain visual processing. This area over here, motor strength, sensation, language. So people in stroke can often lose the ability to express themselves and understand others, the ability to move one half of their body to the other. And the symptoms of stroke reflect the underlying brain. The most important thing to recognize is stroke is a disease of the blood vessels. So how does blood get up to the brain? Well, blood is pumped from the heart through the aorta into arteries through which it travels to the brain. Now, there are 4 main arteries that travel to the brain. There are the carotid arteries. Those are the ones in the front. You can feel the pulse of those. And there are the vertebral arteries. They're called the vertebral arteries because they travel in the vertebrae. So those 4 arteries take the blood flow up into the brain. And when it's in the brain, there's a complex organization of blood vessels. And those blood vessels take that blood to the brain mostly through the anterior cerebral arteries, the middle cerebral arteries, the posterior cerebral arteries. So there are numerous arteries. The way I think about the arteries of the brain, I think about them as trees. There's a trunk, there are branches, and further branches and twigs. So the arteries of the brain are like a tree. Now, if a blood clot travels up that tree, it's going to lodge in a branch, or if you're very unlucky, it might lodge in the trunk and prevent blood flow in that entire area of the brain. And so when we as neurologists approach the brain, we think of, especially stroke neurologists, we think of 2 things. We think about the parts of the brain that are affected and the blood flow to the brain. And one of the most important things are when you have disruption of blood flow to the brain, you have to restore that blood flow early. Once the brain has been completely damaged from lack of blood flow, at that point, establishing blood flow doesn't help. So time is of the essence. That's a theme I'm going to go to over and over again. This is what happens. You have the arteries. I showed you those arteries, the carotid arteries, the ones in the front of your neck, the vertebral arteries, the ones in the back in the vertebrae. And over here, this is the middle cerebral artery. And you see all these twigs and branches. And you have here a blood clot occluding blood flow into that brain. And in this one, it's the right side of the brain, right brain. And the right brain controls the left side of motor function. The right brain can control visual fields on the left side. So when we examine a patient, the way we know they're having a stroke is through their neurological symptoms, and we then extrapolate based on their symptoms which artery we think is affected. So based on our examination, we can get a hunch as to what part of the brain is not functioning and where that blockage is. This is also a stroke. You can see here. This is a large ball of blood, maybe the size of a golf ball or a little bit smaller. When a brain artery ruptures, you get a blood clot that forms. That blood clot is going to spread until the pressure for its spreading outward is equal to the resistance to the brain around it. Now, one of the problems with this kind of stroke is, whereas if you have a lack of blood flow, you have a part of the brain which is damaged, and slowly cells start to die off. This is like someone putting a mass in your head. It pushes the brain tissues around. It can lead to increased pressure in the brain. So this type of stroke, an intracerebral hemorrhage, is the most deadly form of stroke. The most deadly form of stroke. So remember, we said there were 2 main types of stroke. There's a lack of blood flow, and there's a break in one of the blood vessels leading to a ball of blood forming in the brain. Ischemic stroke, ischemic meaning lack of blood flow, hemorrhagic stroke, hemorrhage in the brain. So who is at risk of stroke? There was a great article in New York Times. It's still available on the archive called The Voices of Stroke, where they go through different individuals and their experience with stroke. And if you read this article and listen to their stories, you'll realize how overwhelming and how devastating stroke is. And stroke can occur in anyone. It can occur in a neonate, a newly born baby, because of a heart malformation. Remember, anytime a blood clot forms in the arteries, it can travel into the brain and lead to a stroke. Now, that is not the most common cause of stroke. The most common cause of stroke we're going to talk about next. Now, let me start with this question. We have in this country about 300 million people. How many strokes are there per year in the United States? Anyone want to take a guess? How about a show of hands? A, 8,000 strokes. How about B, 80,000 strokes a year? How about C, 800,000 strokes? 8 million strokes? It's actually 800,000 strokes. So let's talk about that. About 2.6% of the population in the United States has had a stroke. 800,000 new strokes per year, one stroke every 40 seconds in this country. And remember I told you transient ischemic attack? That's when patients have stroke symptoms, but their symptoms resolve and there's no permanent brain injury. We have 500,000 TIA patients evaluated every year, but how many of those patients never present to their doctor? How many of those patients never come to an attention? That is, I think, a call to arms. When you have neurological symptoms, weakness in one half of your body, slurred speech, double vision, loss of vision, trouble articulating and speaking, trouble understanding. When you have neurological symptoms that fade or pass, you have to seek urgent medical attention because a TIA is a stroke. A transient ischemic attack is a covert stroke. So I want everyone to take that message home. A transient ischemic attack is a covert stroke. 1 out of every 15 deaths, it is the fourth leading cause of death behind heart disease, cancer, and pulmonary diseases, COPD, emphysema. But the reason why it's the fourth leading cause of death is because stroke does not kill. Stroke permanently disables. It's the #1 cause of permanent disability. Stroke, we've gotten very good at treating stroke and keeping stroke patients alive, but very often they're left with severe disabilities, such as weakness in one half of their body, trouble expressing themselves, trouble understanding. The costs of stroke are enormous, but most of them has to do with hospitalization, nursing home, and lost productivity. Stroke can take a person in their 50s who's very highly functional. When you lose the ability to speak or use the right side of your body, you can now no longer be a productive member of society. So stroke can really rob individuals of their productivity, and there are immense costs of hospitalization and then afterward placement in nursing homes. So here's a question. What are the risk factors for stroke? Everyone has certain risk factors for stroke. And your risk of stroke depends on the number and severity of those risk factors. So when we think about risk factors, we think about two types. There's non-modifiable risk factors. There's risk factors we can't do anything about, and there are modifiable risk factors. These are risk factors for stroke that we can really take action on to treat or to prevent these. Can anyone think of a risk factor for stroke which is something we can't do anything about? Age, that's true. Can't do anything about aging, and the older you get, the higher your risk of stroke. Can everyone give me an example of a modifiable risk factor for stroke? What is a risk factor for stroke that we can do something about? Smoking, perfect. Smoking, perfect. So I wanted to ask for a volunteer to, we're going to do a calculation of a stroke risk, and if no one will volunteer, we will do a test patient. But does anyone want to volunteer to find out what their stroke risk is? Okay, right about over here. So we're now going to pull up the Framingham Study Stroke Risk Calculator. You can stay seated. We're just going to ask you a couple of questions. Hi, what's your name?
As much as I'm a stroke victim.
Okay. Oh, well, I'll tell you, being a stroke victim, your stroke risk will be very, very high. The calculator is actually designed for people who've never had a stroke.
Okay, well, I've had one.
Okay, so I'm going to have you, I'm sorry.
That didn't last long.
No, my apologies. So there are different stroke risk calculators, but once you've had a stroke, your stroke risk remains high. So let me ask, is there someone else who has not had a stroke who wants to volunteer? Right here in the front. Okay, that'll be much easier. So why don't we start with, okay, so gender? Oh, just the information over there, if that's okay. Okay. Female, age? Uh-oh. Do we want to, another volunteer? Because remember, we talked about, we got to get some of the, you don't have to.
I'll tell, okay. Say 55.
Well, let's say 55, okay. Perfect. And have you checked your blood pressure recently? Do you know what the first number of your blood pressure is? 120, okay, perfect. Let's go to the next one down, 120. Do you take any blood pressure medications? No, let's make that 0. Diabetes?
No.
Okay. Are you a smoker?
Never.
Okay. Let's go to 0 on the smoking. Okay. And let's keep going down. And I think if we pull down, we don't need the BMI because that's not a part of the stroke risk. If we go down to, if we pull down, we'll have your stroke risk. So your stroke risk is extremely low. So if you look at your cumulative stroke risk here, you see that your 10-year risk of stroke is 1.4%. That's pretty low. No one's stroke risk will ever be 0. But you see how what we added in this calculation. We added age. We added gender, because men tend to get stroke more frequently than women. I wouldn't say that. Men tend to get stroke earlier than women. Women tend to have a stroke later on. We had blood pressure, one of the main modifiable risk factors for stroke. Diabetes, smoking, cardiovascular disease, atrial fibrillation, left ventricular hypertrophy. So based on this information, we can get a stroke risk. So I want to get a stroke risk of a patient of mine. So let's go to gender. Let's make that male. This is a patient that I saw in clinic today. And these are not going to be numbers that are too off. Just want to give you. So let's go with a male, age 72. Blood pressure was 175 systolic, was elevated. On blood pressure medications, diabetic, not a smoker, has cardiovascular CVD, cardiovascular disease, 1. No AFib, no left ventricular hypertrophy. Now look at this individual's stroke risk. 31.4% is the stroke risk at 10 years. That's quite striking. However, if we can get that blood pressure down to 140, and let's go ahead, if we can change that blood pressure to 140. No problem? Remember that number, 31.4. If we can get that blood pressure down to 140, that's all right. This is based on the Framingham study. This is the large study in the Boston area. 140, you see the stroke risk now is 19.8%. So you see how stroke risk varies immensely based on risk factors such as blood pressure. And controlling blood pressure can make a huge difference in stroke risk. Let's go back to the presentation. And we'll save questions till the end. But I do want everyone to recognize that your stroke risk is never 0. My stroke risk is not 0. There's no one out there, thank you very much. There's no one out there with a stroke risk of 0. But we had someone in the front row here whose stroke risk was 1.4%. That's pretty good. And I had a patient I saw in clinic today whose stroke risk was in the 30s at 10 years. We can all do things to lower our stroke risk. We can't change our age. We can't change our genetics. We can't change our gender. We can't change a lot of things about us, but we can change our blood pressure. We can quit smoking. We can control diabetes. We can take medicines to lower our cholesterol. We can be more active with our lifestyle. So if we look at a couple things. One is age can't do anything about. The older you get, the higher stroke prevalence. If we could eliminate high blood pressure from civilization, based on 700,000 strokes, over half of the strokes in this country would be eliminated. That's because blood pressure contributes more to strokes than any other risk factor. So keep that in mind. Blood pressure. And blood pressure doesn't hurt you when your blood pressure is high. You don't feel it. But if you're not going to your doctor getting regular checkups, if you're not controlling that blood pressure, and blood pressure is different for different people. Your goal blood pressure may be 120. If you're above the age of 80, your blood pressure goal might be 150. Everyone's blood pressure goal is different. But high blood pressure is a very important risk factor for stroke. And lifestyle. We should all not be smoking. If anyone here is smoking, recognize that smoking accentuates other risk factors for stroke. Alcohol, 1 to 2 drinks per day. If you are a woman, 1 drink per day. If you're a man, 2 drinks per day, no more. And by a drink, we mean a standard, 4 ounces of wine, an ounce of liquor, 8 ounces of beer. Not a very large glass to drink. And alcohol can be beneficial because there are some things in alcohol which actually protect against stroke and heart disease, but you only get that benefit with moderate drinking. The French are great at moderate drinking with food. I just read a recent study showing that if you drink alcohol on an empty stomach, it leads to a lot more oxygenated species, free radicals, a lot more free radicals. Whereas if you drink alcohol with food, there's less free radicals. So if you're an alcoholic and you're drinking alcohol first thing in the morning, that's not good. If you're having a glass of wine with dinner, that's good. Okay? Obesity, a big problem. Big problem. Waist circumference, less than 40 inches in men, less than 35 in women. That is something I think is achievable by all of us. Okay? Certainly, I think that the waist circumference should actually probably be closer to 36 in men, and in women closer to 32, 33. But that, at least at the very minimum, that in physical activity. We can do all these things for lifestyle. We can. So we talked about risk factors, but the question is this: how do strokes happen? It's not like your high blood pressure leads to blood clot forming and going into the brain. It's not like your, it's not like having diabetes leads to, an artery closing off. What happens? Well, there are different mechanisms of stroke. Like, for example, the main one is atherosclerosis. All of our arteries, everyone's arteries in this room has atherosclerosis. It begins in your 20s. There's different levels of atherosclerosis. We all have it. Everyone know what atherosclerosis is? It's kind of a hardening of the arteries that you get with age, deposition of cholesterol, other debris in the artery. And what happens to those arteries is they can get narrow, and more dangerously, they can sometimes have hemorrhage within the arterial plaque, rupture of that, inflammation, blood clots forming on there. So high blood pressure leads to atherosclerosis. High blood pressure leads to changes in the heart, where the heart, just like when you pump iron, your biceps gets bigger. If your heart is pumping at high blood pressure, your heart gets bigger. You don't want a big heart. You want a normal-sized heart. And that big heart might be prone to abnormal heart rhythms, where blood clots can form in the heart. So here's an artery, an angiogram. This artery should look like this all the way through, but here you see there is this irregularity here, and there's a big chunk missing. This big chunk is in the brain. This is the carotid artery I was telling you about earlier. So that's atherosclerosis, and that big chunk there that's missing right there is up in the brain. That is a stroke mechanism, atherothrombosis. All of us in the heart have this left atrial appendage. It's a little thing that sticks out. As long as your heart is pumping, the blood just keeps flowing in and out of that left atrial appendage. But if your heart is not pumping, if it's fibrillating, if you have atrial fibrillation, blood clot forms in there. And that blood clot can beeline straight to your brain. So atrial fibrillation, instead of the heart going like this, it fibrillates the atrial chamber. That's another mechanism of stroke, cardioembolism. So there are risk factors for strokes, and there are mechanisms of strokes. And another mechanism, we talked about the tree, the arterial tree. There's the trunk, there's the branches, there's the twigs. And sometimes those twigs, due to high blood pressure, they just kind of close off, and you're left with a deep little stroke like this. Okay? So that's another mechanism of stroke. High blood pressure can cause those twigs to close off. So there are a lot of different mechanisms of stroke, and there's a lot of different risk factors for stroke. So what happens after stroke? Either you have blood not getting to the brain, or there is bleeding in the brain. Both of those are really time-sensitive conditions. And there's no way to tell what's happening. So if your right side of your arm, your right face, arm, and leg go weak, you shouldn't assume it's an ischemic stroke and take an aspirin. If you're having crushing chest pain, you should take an aspirin. But if you are having stroke symptoms, weakness in one half of the body, slurred speech, trouble expressing words, trouble understanding, trouble with your vision, loss of vision, any of those symptoms, you should call 911. It's important to call 911. Why is it important to call 911? Well, time is brain. Time is brain. In a stroke, every minute the brain loses 1.9 million neurons. Those are the brain cells. 2 million brain cells a minute in a stroke are lost. 14 billion synapses. Do you guys know what a synapse is? It's when one cell talks to another. So Albert Einstein did not have more neurons than we did. He had more synapses. So I'll take synapses over neurons any day. And you can make more synapses. You can't make more neurons. Not yet, at least. And then 7.5 miles of myelinated fiber. Those neurons have these long axons. And those, if you line them up in a stroke, you're losing 7.5 miles of those every minute. So minutes in stroke matter. And if you're having a brain hemorrhage, what we know is 1 in 3 patients with a brain hemorrhage, from when the paramedics see them to when our study nurses saw them in the emergency room, in that hour-and-a-half time period, deteriorated. So that hemorrhage deteriorated. Why? Because a hemorrhage like this, you can survive. This is the same patient. That hemorrhage kept expanding. Here's a hemorrhage in the brain. You can imagine, just look at this area compared to that. Here's a small hemorrhage. This person's going to survive. Same person, look at that hemorrhage. So hemorrhages are expanding. And if you can get to that patient early, if you can lower the blood pressure, reverse any kind of coagulopathy or trouble coagulating, you can really make a difference. So time is brain. And how should you be treated? Quickly, accurately, and efficiently. So let's talk about quickly. The stroke chain of survival. If you want to survive a stroke, the most important thing is to early recognition. So your job is to recognize stroke symptoms in you or in someone else, and your job is to get early EMS activation. How do you activate EMS? 911. By EMS, we're talking about emergency medical services. You want to activate emergency medical services urgently. They want to pick you up, scoop you up, and deliver you to the hospital quickly. The ED has to triage you appropriately, saying this is a stroke patient, they're going to that bed. Evaluation and management, to get the data, figure out what's happening, make a decision. That's where me as a stroke neurologist, I'm part of the decision that's made, treatment decision. And I'll tell you what the treatment options are. The drug, occasionally we use a drug to bust up clots in the brain, and then disposition, okay? All Ds. Looks like there's about 8 of them, 8 Ds. So the stroke chain of survival. The reason why you should call 911 is this. I like this paper from 1993. I occasionally like to show some studies. They did a study showing how long does it take from your stroke symptoms to being seen by an ER physician. If you call 911, 84 minutes after your stroke symptoms, you're being evaluated by a physician in the ER. If you call your personal physician, you're being evaluated by a physician in the ER 270 minutes. Because your personal physician, unless you're some kind of VIP, is not going to pick up the phone and say, hey, what's going on? Okay, call 911. You're going to leave a message. They're going to call you back. If you call some other physician, like a friend or someone you know, 350 minutes. So if you call 911, you're being evaluated by an ER doc within 84 minutes of your symptom onset. If you call your physician, say, doc, I had a little bit of right-sided weakness, you know, I'm in the stroke clinic. I occasionally, in my inbox, find notes saying, doctor, your patient called is having right-sided weakness and trouble with slurring speech. And I'm looking at this saying, oh my God. You know, the nurses know now. They don't put, they find me, but the most important thing is I just call them and tell them one thing, call 911. There's nothing your physician can tell you on the phone if you're having stroke symptoms other than call 911. The paramedics are going to show up. They're professionals. They'll do their job. They'll assess you. In Los Angeles County, they'll perform a Los Angeles pre-hospital stroke screen. They'll transport you to the nearest stroke-capable hospital. And Verdugo Hills Hospital is a Joint Commission, or sorry, is a DMV certified primary stroke center. It is a primary stroke center. This hospital is equipped to take care of stroke patients urgently and effectively. So this is what happened. In 2005, when I was a fellow at UCLA, there was one primary stroke center in Los Angeles. Primary stroke centers can actually take care of stroke patients very quickly and urgently. 2009, and 2012. You see that there's a lot of coverage in Los Angeles. I feel bad for South Los Angeles or South Central. There's a large gap here. And we need to get a stroke center in that area. We're working with St. Francis. But the thing about a stroke center is it takes a lot of resources. It takes commitment. It's not an easy thing to pull off. It's a real team effort. It's a real team effort. You need administration support. You need nursing support. You need, most importantly, emergency department support. You need neurologists support as well. The other thing is this, is if you walk into the emergency room, you may run into some trouble. However, if you call 911, you go straight, it's like if you're at a nightclub, there's the lineup, and if you're a VIP, you go through the velvet rope. If you call 911, you're going through the velvet rope. You have VIP access. If you should, again, I work at LA County USC Hospital. Verdugo Hospital does not have this problem. If you show up to Verdugo Hospital, you're going to be seen right away. But in LA County USC Hospital, if you show up to the ER and try and get yourself registered with a stroke, it might take a few hours. We're working on that. It might. Whereas if you call 911, there you go. There's your bed. This is the model of care which is being developed out there. The model of care is you have symptoms, you call 911. Nothing can happen without calling 911 with symptoms. You do not want to drive to the hospital if you're having stroke symptoms. Those can worsen. You do not want to drive your loved one to the hospital. You want to call 911. EMS can actually make a determination as to what's going on. In Los Angeles County, Verdugo Hills is one of the hospitals doing a research study of magnesium started by paramedics in the field. And Verdugo Hills has enrolled about a dozen patients in this study called FastMag. So in addition to being a primary stroke center, there are meaningful stroke research studies being done in this community and in this hospital. Magnesium intravenous or placebo, a neuroprotectant, go to the primary stroke center, where you get imaging, intravenous medications if appropriate, and get admitted to the stroke unit. If you happen to have a very, very severe stroke, the kind of stroke where intravenous therapies may not be sufficient or there's a large blood vessel that's closed off, then EMS or another delivery system can get you to a comprehensive stroke center where more advanced imaging can be done. The cath lab, where they go in through the artery, I'll show you some slides on that, do some clot disruption, and then the stroke unit. So this is the emerging paradigm of acute stroke here. This is where all the different health systems are moving to. Accurate diagnosis. Yesterday, I got called by Verdugo Hills emergency room for a patient with an acute stroke. Came in 30 minutes after stroke symptom onset. I dialed in with a two-way video. I could see the patient could see me. I examined the patient along with Dr. Kim, who was by my side, doing a National Institute of Health stroke scale. It's a standardized examination we can do via the video. I looked at the CAT scan images. I spoke with the ER doctor. We made a determination to give IV TPA. We thought this person had an occlusion of blood vessel. We gave IV TPA. We gave IV TPA within an hour of that patient hitting the ER door. We then transferred the patient to USC. When we got the patient at USC, the NIH stroke scale, which was at 6, moderate stroke, was now at 2. At 8 o'clock at night, it was 0. So instead of sending the patient back to Verdugo Hills, we're actually going to discharge the patient tomorrow morning. Okay? So that was a real success. As I was giving this, before I gave this lecture, I popped down to the emergency room, saw another stroke case. In this case, there was no treatment option because the last known well time was not established. Remember, these stroke therapies are very time dependent. Okay? So in 1990, there were no really good stroke therapies out there except maybe something for subarachnoid hemorrhage. You don't have to know any of these terms. Just remember, this is 1990. Here's 2012. See, a lot more on the list. So 1990, 2012. You know, this is the kind of stuff, I'm not going to go into that, but just look at the list. It looks pretty good. A lot of interesting things for stroke. So how about this intravenous thrombolytic, TPA? Well, if you're one of 100 patients who get this, you know, 13 additional people who get this out of 100 will be free of any disability from their stroke compared to not getting it. 32 will get some benefit of this, and in 3, we will actually harm people with this therapy. All therapies have risks and they have benefits. Anytime you do anything, you go for any kind of surgery, there's risks and there's benefits. For this therapy, when it's administered correctly in the right time window, you see the benefits outweigh the risks. Okay? If there is a blockage of one of the large arteries, it may be very difficult for an intravenous medication to dissolve that blood clot. In that case, we may have to access the arteries using a catheter and thread that catheter up into the brain. I don't know how to do this. I'm usually in the control room when this is being done. This is done by our neurosurgeons. The kind of expertise to get the skills to do this is not available everywhere. So it just so happens we have 3 individuals, 2 neurosurgeons and a neuroradiologist at USC who are very adept at this. And here's a case that we had 2 weeks ago. This is the carotid artery. Carotid artery. This is the anterior cerebral artery. This is the middle cerebral artery. It's supposed to come this way. Okay? So what we did is we put a little retrievable device, what we call a stent retriever, in the artery, and we were able to establish some blood flow in that artery, and then afterward, establish complete blood flow. That patient did very, very well. And that patient had gotten TPA at an outside hospital. So again, USC University Hospital, we're only interested in the most devastating strokes. 80% of strokes, 90% of strokes are going to stay at Verdugo Hills Hospital. We want to consult with Verdugo Hills. We want patients getting TPA staying here with minor strokes. We want patients with devastating strokes to be transferred to us. Patients with real brain hemorrhages. We are partners in this, but USC University Hospital, actually it's now Keck Medical Center. USC Keck Medical Center is a backup to Verdugo. There are excellent physicians in Verdugo Hills, an excellent emergency room staff. I've enjoyed working with them immensely. They're very good at taking care of stroke. And 90% of the time, they're going to take care of the stroke and you're going to stay here. But occasionally, if you're unfortunate enough to have a severe debilitating stroke, the kind of stroke where you need these types of more experimental therapies, because these therapies really are kind of at the cutting edge. They're not standard. We have 24/7 coverage for that. Here's what it looks like, the blood clot. Now that little blood clot can make a big difference. Here are the warning signs of stroke: sudden weakness or numbness, sudden change in vision, sudden difficulty speaking or understanding, sudden dizziness, loss of balance, sudden headache, the worst headache of your life. We're not talking about a little pounding headache. We're talking about headache that comes out of nowhere and hits you like a ton of bricks. Okay? These are warning signs of stroke. If you have these signs, what would you do? Call 911. Don't call your friend. Don't. You know, there's nothing anyone can tell you except to call 911. I mean, if they tell you anything else, they're telling you the wrong thing. So how bad is a major stroke? Well, this is a questionnaire given to elders at risk of stroke describing what stroke symptoms can do to you. And about half thought it was a fate worse than death. And then, you know, vice versa. So stroke can be a fate worse than death. Stroke is entirely preventable. If you recognize transient stroke symptoms, that's when you want to be evaluated. You don't want to be evaluated when you're having the major stroke. I want to do as few invasive procedures as possible. I want to do as much risk factor education and prevention as possible. That's my love, stroke prevention. So we talked about stroke today. We answered a few questions. We answered a question, what is a stroke? It's a sudden neurological event due to an occlusion of an artery or a blood clot in the brain. Okay? That's what a stroke is. Who is at risk of stroke? Everyone has a certain risk for stroke. Your stroke risk is determined by your risk factors and the number and the severity. There's some risk factors we can't do anything about. Age is the big one. But we can do something about our weight, our sedentary lifestyle, smoking cessation, blood pressure, controlling diabetes, controlling cholesterol. There's a lot we can do. And I can tell you that there's a great study from Oxfordshire, England, Oxford, that showed that if you take a patient with a transient ischemic attack, a TIA, and you do everything for them, compared to taking that same patient for TIA and do nothing for them, when you do nothing, their risk of a stroke in 3 months is 10%. If you do everything, their risk of stroke at 3 months is 2%. So you can reduce your risk of stroke by up to 80% by lifestyle modification, taking an aspirin if it's appropriate, or another antithrombotic, blood pressure, cholesterol, diabetes. Lifestyle, antithrombotic, such as aspirin, blood pressure, cholesterol, diabetes. With those 5 things, you can really reduce your risk of stroke by up to 80%. Okay, we also talked about what to do when you're having a stroke. What you do when you're having a stroke is you call 911. You want to be evaluated urgently, appropriately. And Verdugo Hills is a primary stroke center, actively seeing and treating stroke patients. We are a family, currently, hopefully we'll be even a closer family, working together. Our role, my role, is to do consultations in the emergency room. So you will see me. Because we need to be there quickly, in the old days, the neurologist got called in, came in, drove in, and saw the patient. That takes too long. What I'm going to do is, just like I showed in that picture, I'm going to dial in with two-way video from my computer right then and there and assess the stroke patient right then and there, because time is brain. And rather than have them page me and then I drive over, or my colleagues, Dr. Jean Sung, Dr. May Kim Tenser, Dr. Ben Emanuel, our 4 stroke neurologists, we're going to dial in and do a two-way video consultation. That may seem a little bit odd, but that is it's a very effective way of doing it, and we actually have studies that have shown that that's much more effective than phone calls or waiting for someone to show up. Of course, the best thing is to, for us to be here 24/7, but that's not possible. So we're working together for that. So I think Maybe that's a great, oh, and let me go through the warning signs of stroke. I want to leave you with the warning signs of stroke. Sudden speech disturbance, slurring of the speech, unable to understand other people, unable to express yourself. Sudden weakness, particularly in one half of your body. You know, if you're kind of feeling weak all over, that's not a stroke, one half your body. The worst headache of your life. Loss of vision or blurry vision or double vision comes on suddenly. Remember, stroke comes on suddenly, but stroke is preventable. It's not inevitable, it's preventable. And you can lower your stroke risk.